Hello, and today's guest is Bernie Clark on the Keen on Yoga podcast. It's lovely to have you here, Bernie. We've talked once already. It was a very, very popular episode, and I'm really pleased and flattered that Bernie's agreed to come back to the Keen on Yoga. Welcome, Bernie, and lovely to have you.
It's a pleasure to be back with you.
Yeah, so just have to mention Bernie's trilogy of books, which has had actually a big impact on my own teaching and on many people's practices and teaching, I believe, which is Your Spine and Your... Is that right, Bernie?
Yes, the third one is your
upper body, your yoga. Okay, so read them. They really are great, and I'm not just saying that. They really are really great and well worth a read. So today, without further ado, Bernie, I think last time, I think we talked generally last time, but this time we decided to pick two particular, and let's see if we can get any further than this, but two particular problem areas for people practicing Ashtanga yoga. Now, Bernie doesn't teach Ashtanga. He was an Ashtanga practitioner. If you listen to the last one, he teaches power yoga, yin yoga, and various forms of yoga, but he knows all too well about Ashtanga, I think, and has done it and has tried it out. So he knows what he's talking about in terms of Ashtanga yoga, and he also probably knows that Ashtanga yoga does affect the knees quite often. Many people are listening, I'm sure, and myself included, have had problems with the knees. I've had 2 meniscus operations in my early years myself, and then there's the lower back, probably the second thing to go. So it goes probably knees, lower back, shoulders, and then a variety of complaints from there. But so today, let's see how far we can get. We'll start maybe with the knees, and Bernie's going to explain the knee joint and why this happens and what we can do perhaps to help with that. Over to you, Bernie. Yeah.
Well, as you say, I've been a fan of Ashtanga yoga since the early 2000s. I went through a variety of teacher trainings. I used to teach at a center here in Vancouver called City Yoga at the time.
I remember it.
Yeah. Mike Dennison brought in a whole bunch of people like David Williams, David Swenson, Tim Miller, Nancy came by. So I've had a chance to study with a lot of these people and put their wisdom into practice and teaching. But then I reached a point where, like you, I broke both my knees. And it's surprising when I started to ask about broken knees in the yoga world, just how many teachers have blown their meniscus. I mean, it's not just you and I. Eric Schiffman did it. David Life did it. Leslie Kaminoff did it. So many people have blown their knees because their hips weren't ready to go do Lotus. And in Ashtanga, there's a lot of poses where you need Lotus or half Lotus, and all the pressure seems to end up in the knees if your hips aren't open enough. So that's what I did. Eventually, I had the arthroscopic surgery to trim away the problem. And other people like Eric Schiffman, he didn't get the operation, but he just worked with weights and light weights and squats and so forth. And David Life, he did a lot of Vajrasana, sitting on the heels, and he claimed that helped his knees. But I talked to Richard Freeman about it one time, and he just kind of commiserated with me and said, well, there's not much blood flow into this region of the body, so they don't really heal themselves very well. So he kind of said, an operation's probably not a bad thing.
That's a total coincidence. Sorry to interrupt you there, but was Richard Freeman was the catalyst for me as well. Did a workshop in Oxford. I was walking home with him. He was outside. I was chatting to him as we walk into an Indian restaurant, in fact. And I said, look, what should I do? And he said, you know what? Yeah, there's no problem. Just have the operation. So that, he really was the catalyst for me as well, to have the meniscus. And I have to say, I was fortunate. I was in my early 20s and it worked, but I'm not sure about now how it would go at 45.
Well,
Sorry.
The surgeon I had my operation with, he had a torn meniscus and he didn't get the surgery. He says a lot of people just live with it, and eventually the pain may go away. So I decided it was interfering with my yoga practice, so I wanted the pain to go away. And it's kind of ironic, in the Hatha Yoga Pradipika, they've got these 15 asanas listed, and they always have the selling point. There's quite a marketing manual in those days. And it says Padmasana, our famous lotus pose, is the destroyer of all disease, available only to the very wise. Only a few can do it. And in my experience, talking to a lot of other yoga teachers, Padmasana is not the destroyer of disease, it's the destroyer of knees. And so many people are trying to get Padmasana and they don't have the external rotation available in the hips, and they take it out on the poor knee.
It's a typo.
Let's talk about the knee. Now, I don't have my bones. Usually when I'm teaching the anatomy courses, I've got the bones with me and so forth. But the knee is kind of a unique joint in that it's not a bone-on-bone stop. Like if you open your elbow out to the side, what stops you from extending further is at the end of the ulna, the proximal end of the ulna, there's a bit of a cave or a peak. It's called the olecranon process, and it fits into a cave at the end of the humerus. And when those two bones hit, you just can't go any further. The same with your hips. When you open up your hips, eventually the femur is going to hit the pelvis, and that's it. That's the end of the game. It's called compression. But with the knees, there's no bony stop there. And when I first started to research anatomy from a yoga perspective, I totally misunderstood what the kneecap was. I always thought the kneecap was right between where the end of the femur is and the beginning of the tibia. And it was kind of spanning those two bones. And I thought, well, maybe it's the bone of the kneecap that prevented me from hyperextending. But then once I started to study this more, I realized the kneecap never touches the tibia. It never goes close to your shin bones. It's always on top of the femur. And as you bend the knee, as you flex the knee, it just slides down. And then as the femur comes to like a 90-degree angle over top of the tibia, the patella just goes right into a little valley. At the bottom of the femur, there's like two little legs of a rocking chair, you know, the rounded part of a rocking chair. These are called condyles. At the end of the femur, at the end of our humerus, we got these rounded bits called condyles. There's two of them. And in between, there's a valley. And it's in that valley that the patella goes in. So the patella never actually touches the tibia. So there's nothing bony stopping the knee from extending or flexing or hyperextending. It's all soft tissues. Mostly these things called ligaments. Now in the knee,
you're saying you could kind of hyperextend the knee theoretically.
You not only could, you should. Everybody hyperextends their knees to varying degrees because we're a biped. We're one of the only true bipeds in the world that doesn't have a tail for counterbalance. And to help us walk, the back leg, when you're walking, hyperextends. On average, about 6 degrees. So 5 for women, 6 for men, but it doesn't matter. The normal range, by normal I mean 95% of the population falls within this range. We hyperextend between 1 degree to 17 degrees. So the knee is designed to bend backwards a bit. And that allows us to bring the foot way behind us as we walk forward. If you ever had a knee replacement surgery and the surgeon didn't pick the right prosthetics and you couldn't hyperextend, you had completely straight legs, you would walk very awkwardly because you need to have that little bit of hyperextension. The fears we have in many of your yoga classes of hyperextending the knee is not really well founded. There are 2 ligaments that really stop the femur and the tibia from going over top of each other. There's 4 ligaments in all. There's 2 going down the sides called the collateral ligaments. And these prevent the knee from doing abduction and adduction. You don't want the tibia to go side to side underneath the femur.
Yeah, that would be bad. Okay.
Yeah, that's a bad movement.
Yeah.
So we got these collateral ligaments that keep that movement from happening.
Yeah.
But imagine if you had 2 2x4s stacked on top of each other. The top one we'll call the femur. The bottom one we'll call the tibia. Now you can imagine you could slide that top one off the front of the bottom one. Well, that you don't want. So that is restricted by something called the posterior cruciate ligament. And it goes from the backside of the tibia. If you think about the top of the tibia, it's called the tibial plateau. The PCL, or the posterior cruciate ligament, goes from the backside of the tibial plateau to the front of the femur. And it prevents the femur from going forward or the tibia from going backward. And then from the front of the tibial plateau to the back of the femur is the anterior cruciate ligament. So anterior or posterior refers to its arising on the tibia. So it's starting from the front of the tibia going backwards. That's the anterior cruciate ligament. From the back of the tibia going forward is the posterior cruciate ligament. And they cross in the knee joint. That's why they're called cruciates. The Greek for crossing.
Yeah.
So it's the ACL that prevents hyperextension. The ACL is a very tough piece of tissue. It can withstand 2,300 newtons of force in an average person. Now, nobody knows what a newton is.
No.
They do, but usually it's in a dynamic movement, like playing soccer or football or rugby, and they get tackled, or they're running and jumping, or they're skiing and their skis go one way and the body goes another way.
Yeah.
And in that dynamic one-time movement, you're putting tens of thousands of newtons of force into that ligament. But standing on one leg, like a lot of people are freaked out about in, say, Nataraja, the king dancer,
Yeah.
or even in tree pose or triangle pose, you'll see somebody's knees hyperextended and they get all freaked out about it. You're going to break your knee. Well,
Right.
if you do the trigonometry, say you've got a 120-pound woman doing triangle pose, so that 120 pounds is distributed over 2 legs, and she's got maybe a hyperextension of 15 degrees. She's putting about 40 or 50 pounds of pressure on the ACL. Now, as I say, most people don't know what a Newton is, but that tissue can withstand 2,300 Newtons of force, which is equivalent to about 510 pounds.
Okay. Yeah.
That's in a normal person. Athletes, they train their ligaments, they can withstand much more than that. But the average person can take 500 pounds on the ACL. And in a triangle pose, you're only putting about 30 pounds in it.
In Ashtanga, it's often the warrior. When you see the old pictures of, say, Krishnamacharya, or I think even Sharat does a warrior with the knee over the ankle, and people say, oh, don't put the knee over the ankle. And there's this whole thing particularly with the warrior, I think, and where the knee should be placed. But I mean, the cruciate ligament, you don't hear so many people tearing it within the Ashtanga. I mean, I had students that have gone skiing and torn it, for example, and still recovering from it, because it's quite a serious one, right? A lot more serious than a meniscus tear generally.
Meniscus tears are much more common in yoga than ACL ruptures. Now, it is possible somebody who is an athlete and they've damaged their ACL and it's hanging on by a thread, and they come into a triangle pose, that one person might break it. But chances are they're going to break it just climbing stairs or walking down the street, because that's also putting pressure on it. So it's very, very unlikely that anybody in a yoga pose is going to hyperextend the leg so much that it's going to damage this tissue. We don't put anywhere near the tolerance to it. And the other factor is every tissue needs exercise. Every tissue needs a load, needs stress. If you don't stress your cruciate ligaments, they're going to atrophy. They're going to get weaker and weaker. So athletes, dancers, gymnasts, they're constantly stressing their knees, and that makes these tissues thicker and stronger. So a professional athlete, their ACL could withstand 10,000 newtons, like almost 1,500 pounds of stress, because they developed it through their practice. So the fear we have in yoga of hyperextending the knee, I think, is very unfounded, except for the 1 or 2 people who have a real serious injury, or they're in their 90s and just from a lifetime well led, their cruciates can't take that much stress anymore. But again, if your cruciate's that weak, you're probably going to damage them anyway, just through daily living.
What about, where does the knee get damaged then? More commonly, are there different strains of meniscus tear? You mentioned people trying to heal them themselves. That's a common idea. Can one heal the meniscus? There seems to be this idea about lack of blood flow there. And so many people are debating, should I or shouldn't I have an operation on the knee? What would you say to all of that?
Yeah, everyone is different, of course. That's the whole reason for my books, is that we're all unique. And what works for one person isn't going to work for another person. So the meniscus, just to go through the anatomy of that, it's like a little gasket. The 2 ends of the femur and the tibia, they don't fit together very well. The top of the tibia is kind of flat, but the bottom of the femur is rounded, like a rocking chair. So they don't fit together very well. So Mother Nature has designed these 2 little C-shaped gaskets, little pieces of cartilage that fit between the 2 bones, and they kind of help to guide the movement of the femur. So when the femur flexes, it not only kind of goes backwards, but it also moves forward. So there's a turning and a gliding forward. And in that gliding forward, it kind of keeps the end of the femur inside the center of the C of the meniscus. So the meniscus are a little bit like guides, but also when the knee is completely straight, it's a shock absorber between the weight of the upper body onto the tibia. So it kind of helps to make the 2 surfaces more congruent. So it's shock absorbing and it guides the movement. The meniscus on the outside of the leg, called the lateral meniscus, it is free flowing. It can kind of slide around a bit more. But the meniscus, the little C-shaped cartilage on the inside of the knee, it actually is part of the medial collateral ligament. It's like one tissue that's just grown together. But anatomists will cut them apart and show 2 different things. So if you look in an anatomy book, you'll see the meniscus separate from the collateral ligament, but it's all one continuum, like one rainbow of tissue. And because it's all continuous, it doesn't move around as much. It can't slide out of the way. And what happens when we do something like a lotus pose, we have to externally rotate the femur at the hip socket. Now, most people get stopped eventually by the neck of the femur hitting the back rim of the hip socket. And once those two bones come into compression, you can't externally rotate any further. Now, some people, they have the hip socket facing way out to the side of the pelvis. It's called retroverted, and they can easily externally rotate as much as they want. But some people have the hip socket facing forward. These tend to be sprinters and cyclists because that allows the knee to go straight forward and back. Whereas those who have the acetabulum,
but that's genetic, right? They didn't develop that by being a sprinter or a cyclist. It's just genetics, and they happen to be good at those things, right? So some people really shouldn't be doing lotus or anatomically unsuited in the first place to doing this position.
Yeah, we generally choose our sports depending on what our bones allow us to do.
Mm-mm.
Like hockey players here in Canada, hockey is a big thing. You have to push your leg out to the side to skate. And so that requires more of an externally rotated pelvis. If you can't do that, they put you on goal. So you tend the goal. That requires internal rotation, so you can get your legs on the ice to stop the pucks. So the bad skaters become goalies, and the best goalies are terrible skaters because of the way the bones develop. So we kind of choose the sport that we're good at because of our bones.
Yeah.
So if you've got these anterior facing acetabulum, you're not going to be able to externally rotate too much. And that means when you try to get your foot onto the opposite thigh, that's not coming from the hip socket. That's coming from the knees.
Yeah.
Now, when you bend the knee, when you flex the knee, those side ligaments I talked about, the collateral ligaments, they become lax. They kind of fold up a bit. And the same with the cruciate ligaments. They become a bit lax. And now when the knee's bent, you can twist it a little bit. You can wiggle it side to side. So a lot of people
it's not a hinge joint, is it? Yeah.
It's basically a hinge joint. It's called a condyloid joint, but when you bend it, it can twist. So a bent knee can twist a bit. But when you straighten the leg again, you want to make sure it's not twisted. Because the straight leg, those ligaments become taut once more, and you want to make sure it's straight before you straighten the leg.
Yeah. Because it needs that twist to go into lotus, right? There is a slight twist in it, and that's the complication, isn't there? It's like, because it has to slide and go up, as it were, like to be very basic about it. If it was just a hinge joint, you could, if it just hinged completely, you'd have to have super open hips.
Yeah, if like Paul Gurley has very externally rotated hips. So when he comes into lotus, there's no twisting at all from the knee.
Pure hinge.
He just, yeah, it's pure hinge, like your elbow. Imagine I'm just twisting the elbow enough at the shoulder that I can just straighten the elbow, and I just put my hand on the opposite shoulder. There's no stress in the elbow at all because it's all coming from the shoulder. Well, in the hips, if you've got really open hips, there's no straining you need at all. You just say, okay, do it like this, and they just flex the foot and flex the knee and bring the foot on the opposite thigh. But if you're like me and I can't quite get there, then it has to come from the knee. Now, what happens then is as you're bringing the foot up on the opposite thigh, you're twisting the tibia, and the inside bone of the tibia is now compressing to the inside, called the medial part of the femur, and that's where this little gasket, the meniscus, is. And that gets caught in between there, and it gets crushed or torn. Some people may feel it on the outside of the knee, and that's the lateral collateral ligament being overly stretched. But for most people, it's that medial meniscus that they tear because they forced their foot into lotus because they couldn't externally rotate enough of the hip.
Right. And so most people, it's a medial.
Yeah, it's always the inside one that gets torn.
It's always
in yoga.
Okay.
Yeah.
Right.
Yeah. Because that's where the pressure goes in the lotus pose. And unfortunately, inside this joint capsule, there's no blood supply. The cartilage is fed mostly through synovial fluid. The nutrients it gets is from the fluid, and that comes from the surrounding cartilage and a few fibroblasts, some other cells in there. But there's no blood vessels going into it, or at least not the healthy cartilage. Sometimes as you get older and the cartilage gets damaged, blood vessels and nerves will actually grow into the cartilage. This happens more in the back than in the knee, but that's not a good sign. That's a sign of old cartilage that's now stiffening up, and these blood vessels and nerves are getting in there, causing havoc, and now you start to feel a lot of pain. So
Right.
hopefully there's no blood supply into your cartilage, which means it doesn't heal very well because it's not got the nutrients. It does get some nutrients from the synovial fluid. So if you move the knee constantly, just flexion and extension, you can start to circulate that synovial fluid, and that hopefully can bring some nutrition to the knee.
Does it heal itself?
It depends
then?
on. Sorry? It can.
Does it
for
heal
some
itself?
people.
It can, right? The meniscus can actually heal, and people can have a Lotus and a normal practice of Ashtanga anyways without operation.
Yeah, depending on the person and the pain.
Right.
Now, here's a little secret. Most people, I'll talk about men anyway, the studies was done on men. Most men, when they get to be about 45, I shouldn't say most, about 35% of men at 45 years old have a torn meniscus, but they have no pain.
Right.
It's asymptomatic. So chances are 1 in 3 people that are over in their 40s or older, they have a torn meniscus, but they don't feel it. Because also there's no nerves right there as well. So there's very few nerves there. So a lot of people will tear this thing and they don't even notice it. So a lot of people can just get used to the pain, or the pain goes away by itself. Doesn't mean that the problem's gone or that it's healed. It doesn't bother you.
Thing is, they probably would feel it if they wanted to do Ashtanga, wouldn't they? Then it would start to be a problem, and which is the kind of question of like, how much do you need to do the postures? Which is my question in the first place. Don't you think so? I mean, the doctor would say, "Oh, do you really need? Do you need to do that?" I mean, this is like a long time ago, before doctors had probably seen this a lot, which is probably the case now. And they go, like, what are you doing? And they go, "Oh, like this is what I'm doing." And they'd go, "Well, why are you doing that? Do you really need to do that? How are you otherwise?" And to be honest, I was okay. I wasn't too bad, But people had said, "Well, if you don't say it's affecting your life, they won't, give you the MRI and put you on the operation schedule." So I said, like, it's I can't run for a bus. We used to take buses a lot in London. I can't do anything like that. And they said, okay, but otherwise, I don't think they would have. And at that time, I really wanted to do those things and practice Ashtanga like you. I really wanted to do that. I mean, now I think I've torn my meniscus again, but I'm not so bothered about deeper knee stuff, so that I live with that, and I do Lotus and, blah, blah, blah. But at the time, if you go to advanced series and you want to do things like Mula Bandhasana, rolling over the knee, like that, I mean, you've got to have a good knee for, you're not going to muck around at that stage, which kind of, I suppose, brings me on to a question is like, what do you think about that kind of stuff with the knee, which is using that weird kind of movement, which is not just a hinge joint, it's kind of rolling over the knee. I mean, that it always struck me that would not be a good idea for the long term. You want to strengthen the leg more and not make it overly flexible, the ligaments around the knee,
Yeah, this has always been a problem with some of these more well-known Ashtanga teachers. Like, I remember David Swenson telling me that every time David Williams would go down to the beach to go surfing, he'd pop his knees out.
Yeah.
So he had to work on stability more. I don't worry about hip mobility anymore. I mean, the Lotus pose to me, as I said, it's the destroyer of all knees. It's a high-risk, low-reward pose. And there are many high-risk, low-reward poses in yoga. Like, I'm almost 70. I'll be turning 70 in 2 weeks. I don't do headstands anymore. I've done them up to my 50s and 55, and then I was starting to get neck tweaks. And now the last MRI I had, I've got degenerating discs in my neck, probably because I was doing too many headstands. Why do I need to do headstands? Legs up the wall will serve me just as well. So another high-risk, low-reward pose. So yeah, Lotus pose looks great, but you don't need it. Now, unfortunately, in Ashtanga, as you said, when you get up in the series, there's so many poses that require it. Well, you're just going to have to do a Larry Schultz and say, no, I'm not going to do those. I still like this part of the practice, but I'm not going to do that.
Any advice for people that maybe, don't want an operation, want to see if they can do the healing without it? Are there certain poses? And I often say, like, it looks to me like maybe you need to strengthen the muscles around the knee. That was often said when I was suffering, that the knee muscles themselves were weak. So the ligaments were taking the force. And you mentioned before athletes training the knees and strengthening. Do you think there's any truth in that? Go to the gym, do a bit of that, because yoga does seem to favor flexibility a little bit more than strength.
Well, there's a physiotherapist in England, Adam Meekins, who has a saying that you can never go wrong by getting strong.
That's good.
I think regardless of what you got, strengthening the knees is going to help you throughout your life. So Now,
Yeah.
sure, do strengthening of the knees. You don't probably need your knees to be more flexible. If you can sit on your heels, you've got all the flexibility you'll need in your life. So yeah, strengthen the knees. But let me share with you a fascinating study I saw. It actually was the subject of a documentary about 30 years ago. There was a surgeon, an orthopedic surgeon, who specialized in knee arthroscopy in a hospital in Texas. Now, as you know, when you do the surgery, they do two things. One is they do a lavage, which is a cleaning, changing the oil. They take all the synovial fluid out and they replace it with saline. So they flush away all the gritty bits. Like there's a lot of broken cartilage and bones in there that create the grounding sounds. They flushed all that out. And then they also cut away the torn part. And this surgeon was wondering, what is it that makes my patients better? Is it the trimming away of the broken cartilage, or is it the washing out? So he went to his department head and asked for permission to do a study. He would have 6 patients where you just do the lavage, 6 patients where you just do the trimming of the knee. And she told him, well, you need a control group if it's going to be a proper scientific study. And he said, control group? What do you mean by that? He said, well, you're going to have 6 people that you don't do anything to.
Yeah.
Well, they'll know that they didn't have the operation. Well, you figure it out. So what he did is he came up with 3 groups. One that he did the cutting, one that he did the washing. And the third group, he simulated an operation. He put the video up, he made 3 incisions in their knee, but he didn't trim. He gave them general anesthetic, and he even said the same script to his surgical crew that he would have anyway. And then a documentary group from the Discovery Channel followed these patients for the next 2 years. And at the end of 2 years, all of them had the same recovery. Even
That's
the ones
incredible.
that didn't have anything done to them.
Didn't have any operation.
Right.
Wow.
And this documentary crew was asking one of the persons who was in the control group, he was out playing basketball with his grandchildren. And before the surgery, the fake surgery, he couldn't even hardly walk. Now he's playing basketball. And they asked him, you were part of the control group, right? And he just dribbled the ball, sunk a basket, and said, the mind's an amazing thing. But another guy that they talked to, he called up the surgeon. And the surgeon said, hey, how you doing? How's the knee? Oh, fine. It's all great. Did the documentary crew come to talk to you? Yeah, but they're confused. What do you mean confused? They thought I was part of the control group, but my knee's fine. And the surgeon said, you were part of the control group. Now, that was a small study, about 15 people or so. About 10 years later, New England Medical Journal did a bigger study with hundreds of people and found the exact same thing. Then 10 years after that, there was a 1,000-person study. This was talked about in the British medical journals. 1,000 people, all in the same 3 groups, and exactly the same thing. So I got better with my surgery. You got better with your surgery, but we don't know what did it. Now, my personal speculation is he still faked the incisions. So maybe it's just the inflammation that happened from that. In the inflammation, the body responded and said, oh, this knee is damaged, let's go heal it.
That, to me, I struggle with, I think, because as soon as I came round, even though my knee was really inflamed, it felt different straight away,
Yeah.
I could
For
feel,
me too, the pain was gone.
Yeah, I could kind of feel it's okay. It could, even though I couldn't bend it that much, I knew something was different about it, So I don't know. I mean, I totally agree that there is something in the mind, but I'm not sure how far I would go down that road,
Well, what they do when they do that operation is they pump saline into the knee to make it swollen up. They actually separate the bones apart so that the surgeon getting it in there and cut away the stuff. So whether you cut it or not, just that swelling up creates a huge change. You no longer got pressure on the meniscus because everything has been blown apart. And that's that swelling that takes 6 weeks or so to really get back to normal again.
But they didn't do that with the control group at all. Or did they do that as well with the control group to give them the information?
I don't know if you actually did the injection. No, that would have been a washing. So I don't think they did.
Right. Yeah. It's also kind of
you hear people like Eric Schiffman didn't get the operation. He just worked with light weights and a lot of deep knee bends. David Life, he just did sitting on his heels. So what I did after my operation, then eventually I got both knees done, my recovery was basically to sit on my heels with the doweling tucked up behind the back of my knees. So I have a little 1-inch piece of doweling, and I would sit on a couple of blocks So I wasn't sitting right on my heels, and I'd pull this in the back of the knee, and I'd sit there for a couple of minutes.
Does
and
that
this is
actually
from
work?
the younger tradition.
You know, the putting
Well, I
something in
didn't
the
have
knee,
any
because
pain afterwards.
you often see that, you know, and I remember John Scott advising that when I had my meniscus problem and I hadn't had the operation, oh, you put a sock in the knee, you know. But then latterly, Mark Darby would say, oh, you know, that's really bad to create a space in the joint like that. That's a bad idea. And I see people up to this day doing it, and I'm not sure. What do you think?
Well, I think it's okay. I don't think you're actually literally creating a space. That's what I was told. Visualize you're opening up the knee. But what I think you are doing is you're putting pressure into the cartilage and all the other soft tissues around the knee. And all tissues need exercise. So I think by stressing the knee this way, you're stimulating the cells inside the cartilage, the chondrocytes, the cells inside the joint capsule, the fibroblasts, to turn on and create more synovial fluid and heal the knee. So I don't literally think you're pulling the knee apart, but I do think you are putting a stress
putting
there.
Something underneath it. Yeah. I mean,
or
obviously,
even
people
just simply sitting on the heels. I now don't think you actually need the bolster or the block or something folded up. I think just sit on your heels as often as you can will help the knee stay young.
Vajrasana as well. I was recommended go to Vajrasana. You're lying down with a knee bend. You know, try and stimulate and that seemed to help a little bit. But I must say, nothing really. I mean, it was 2 years both times. I kind of waited a couple of years, and nothing got better. You know, and people often ask, like, oh, when should I know? When should I decide? Should I keep trying to do? Should I keep trying to do it? But I mean, for many people, it's just not. For me, it wasn't an option. I could not put that knee. It was just not up without kind of taking a general anesthetic. It was so painful. But I mean, for many people, like you mentioned, they're kind of stressing the knee. I mean, how far? I guess there's no possibility to generalize. Is it how far to go in that?
Well, a general rule of thumb is if it hurts, don't do it. You've gone too far.
Yeah, that's pretty sensible.
But if it's just uncomfortable, that's okay.
Yeah.
Exercise is not comfortable. You need to stress the tissues. You need to load them. No load, no health. Too much load, no health. It's an N-shaped curve. So you got to find the Goldilocks position.
Yeah. And what about, I mean, maybe you don't know about this, but what about people say, well, if I can do it on one side and then I've got a torn meniscus on the other side, I can't do. Should I just do the same on both sides? What do you think about that idea? Any ideas?
Well, in the last volume of my last book, Your Upper Body Yoga, I've got a section on asymmetry and proportions. And in there, I address this whole thing. There does seem to be a bit of an idea around in some yoga teachers' minds that we must be perfectly symmetric. So only go so far on one side as you can go on the other side.
Yeah.
Well, I'm not sure where that comes from because your right arm, if you're right-handed, is much bigger than your left arm. We do all sorts of things with our right hand all day. You're telling your students, make sure you brush your teeth with your left hand too, because we are asymmetric. One shoulder's higher, one foot is longer, one leg slightly longer. Our heart is on one side, our liver's on the other side. Why do we think we have to be symmetric? What we want to be is functional. And as long as you're functional, who cares that one side of the body doesn't look like the other side? That's an aesthetic. That's just some pleasing view that some people have that has no functional rationale to it.
Right. That's a great piece of information. Yeah.
Now, of course, anything can go to a limit. Like if your one leg is 3 inches shorter than the other, okay, that's going to affect your daily living. But a half an inch or a quarter an inch isn't.
Right. So, I mean, addressing kind of great asymmetry is one thing, but, just a lack, a kind of a natural slight imbalance is another thing, I think, is what you're saying, right?
Sure.
Yeah.
Most people have a slight scoliosis. Their spine is slightly twisted or curved to one side. They might find they can really twist easily to the right, but not as easily to the left. And they may not realize it. It's just their spine has a slight twist to it. Does that mean you should never go to your natural limit on the right? Well, sure. You want to go to where you're exercising the tissues. So go to where you stop, and then go on the other side to where you stop.
Right, but they shouldn't be trying to kind of make it equal, like go to the other side that's weaker and do that the same. You don't think
so?
One
asymmetry I've got, my right arm, I can extend the elbow to 180 degrees. So it's completely straight. Sorry, my left arm.
Yeah.
My right arm, I can only extend to about 170 degrees.
I can see
cannot
it. Yeah.
straighten the right arm.
Yeah.
And when I have my arms out like this, I can't tell you how many teachers have tried to correct me and down to make my right side look like the left side. And I just can't get the bones to shape really differently on one bone to the other. So it won't go that way.
I mean, it is aesthetically, there is this thing, isn't there, about the pleasing nature of symmetry, and that things should be the same. And I totally agree. And I think a lot of people get into trouble and get into injuries trying to make both sides the same. You know, it's like, well, one knee does this, one hip does this, so the other hip should do the same thing. And it's like, well, of course it doesn't, but they push it to be the same, and that's where the injury lies. What do you think about the
Well,
idea,
think
especially
of
in
the
Ashtanga?
Japanese Zen. Think of the Japanese Zen artists. They don't have perfectly symmetric pictures. They have balance. So you might see
Right.
a drawing of Mount Fuji, and he's in one corner, and then there's a cherry tree blossom on the other side. So it's not perfectly symmetric, but it's balanced. That's what we want to seek in our life, is balance, not symmetry. Just
Yeah,
be
that's a nice
balanced.
analogy. Yeah, totally. What about then this idea of doing lotus on one side, lotus on the other side? You know, like alternating where you cross your legs and all this stuff. You know, because in Ashtanga it's always like, you know, one side over the other side. Like if it's lotus, then it's, what is it? Left first and then
Yeah,
right, and then people are
yeah,
asking me actually today, even today, where the legs cross behind the head, because traditionally Ashtanga, you put your left leg behind your head first if you're doing two legs, for example, behind the head, and then the right leg, you know, and why it should be that way round, and well, there's no good reason, I think, for any of this really, apart from one, the favouring of the right as higher and the left as lower, which is in
right.
all cultures, but we see. I don't think that, and I think if one could, you should cross the legs all the time. I mean, Chuck Miller saying to me, cross your different legs when you're jumping back. Cross one leg and then cross the other leg, and trying to keep it symmetrical. But Ashtanga, you get in trouble for that kind of thing. What do you reckon?
Well, I've seen the same in the Zen tradition. When I first learned Zen, you had the left foot in first and the right foot in front of the left foot. And
Oh
the,
yeah,
the right hand was under the left hand. And make
yeah,
sure
yeah,
you,
yeah.
you don't get it the other way
You got to
around,
do that.
because
Yeah,
that's the way
yeah,
the Buddha did it.
yeah.
But then I found another Zen tradition that said, why are you doing that way? You think you're a Buddha? You got to do it the exact opposite. So I gave up trying to figure out. It's just an aesthetic. Somebody's come up with one way of doing something. It worked for their teacher. It's going to work for me. But I agree with you. I think, just use your full range of motion by working both sides. Not
Mm,
that they have to be equal, but I want my right side to have as much range of motion as it can have, and I want my left side to have as much range of motion. So if I'm always putting my left foot in first and then the right foot, when am I going to work my left leg to its full range of motion?
mm.
And that's usually why most people who break their knees, they break the right knee worse than their left knee, because it's the one that has to go up higher. So there's more
Yeah,
torquing in
yeah.
that knee. And certainly in
Mm,
my case, my right knee was much more damaged than my left knee.
mm, mm, mm. Yeah, I think that's the case, and I think people will justify it by, well, it's energetic, though the
Yeah.
sides are there's something kind of magical and energetic about it, and I just think that's rubbish, and a shame that this kind of this kind of thinking goes into something which is much more practical. I don't think it was there in the first place. I don't think Patabi Joyce or Krishnamacharya was really thinking that much about it, apart from slight cultural protocol sometimes in terms of right
Yeah.
first and then left, but there's nothing special about it. It seems natural then to move on to the hip a little bit, and you mentioned left over the right going up higher, and I have to say now I am suffering a right hip pain. I have been for maybe since I was 40 or so. And I think sooner or later something's going to have to be done about that, unfortunately. And I was wondering, well, where does this come from? And I think, well, yeah, actually, it's all that lotus probably, and putting the right side first, so it takes the torsion on the hip takes more, is that much bit more, because you're having to pull up that leg. Same with the leg behind the head, because the right leg goes
Yeah.
second, so it goes back further, and there's a lot of leg
Right.
behind the head in the advanced series, which I was doing for years. Do you want to? I mean, rather than going in the lower back, well, maybe we speak about the hip, because it seems the natural kind of flow from the knee to the hip, and I know in Ashtanga now there's a prevalence of hip replacements that in all yoga, I think. Have you heard about
Yeah.
that? Yeah.
Oh, yeah. Um, there's a couple of comments I can make on that. One is, it depends on, again, the orientation of the hip sockets. Like my left hip is much more retroverted, so I found it easier to do external rotation than my right hip. So it wasn't just the fact that the right was going on top. For me, the right hip was pointing a bit more forward, and that made it harder to go into it. So we can't really tell, is it because you're always doing the right leg on top, or
Yeah.
maybe your hip socket is just meant more antiverted facing forward, or maybe a bit of both. And also it's to do with the angle of the neck of the femur too. It has a role to play in all of this. There's a torsion to the femur, which will make external rotation more available or less available, depending on how much twisting your femur has.
Mm.
All long bones in the body have a torsion to them. Our tibia have about a 20-degree torsion, which means when we're standing relaxed, our feet are pointing outward, despite most yoga teachers who are alignment focused saying feet must be parallel.
Yeah,
That's not the
yeah.
neutral position, because
Right.
the tibia
Yeah,
has this twist. So the front of
yeah,
the knee points straight ahead, but the ankle is pointing out to the side. Well, the
yeah,
femur has that, the humerus has that. So all of our long bones have a twist to it. So
yeah.
depending on how much
And it's
twist your femur has
yeah.
and how much retroversion your hip socket has, you're going to get more or less stress on one side or the other.
And I didn't realize that there's actually the hips are potentially structured differently. So one hip is more retroverted, as you say, than the other. Because if I look at
Yeah, we're
myself
not
doing a
symmetric.
squat, if I go to the gym, right, and I do a squat where I've got a bar on my shoulders, right, that one, and I can look in the mirror and I can see that one hip likes to do with the toe facing slightly forward, but the other one likes to do with the foot facing much more outwards. And
Well, look
I
at people
assumed I
doing
should try and
Shavasana.
correct it, but maybe not then.
No.
Yeah.
Look at
Right.
people in Shavasana, and often you'll see one foot is pointing up, the other foot's going out to the side. And right there, you'll see an asymmetry. Now, the legs
Right.
are perfectly neutral. That's what we want. We want neutral. We don't want aesthetics. So imagine if you're standing in mountain pose, or the back feet in down dog, or the back foot in warrior pose. One person's neutral is going to have the foot pointing straight ahead. The other person's neutral, the foot's going to be pointing outward. But then a teacher comes along and tries to make them both point straight ahead. Now that foot that's pointing outward, to come straight ahead, you have to internally rotate at the hip socket. And I think this is where a lot of the hip problems come in. And you need to play with the bones. And during some of my workshops, I bring the bones so the students can play with this. But flexion of the femur at the hip socket never leads to any impingement, because the bones are just kind of turning over each other nice and easily. But if you internally rotate at the hip, that's bringing now the neck of the femur in front of the hip socket. So as you now flex the hips, now the front rim of the hip socket impinges on the neck of the femur. Now, it depends on the person. For most people, this will never happen. But for somebody who's externally rotated and they have to bring their feet pointing forward, they're now internally rotating the femur, adding the flexion at the pelvis. Now they're starting to work on the labrum, and they can start to tear the labrum. And if you get too much, you're working on the neck of the femur and the actual bone of the hip socket, and eventually those tissues can wear out, and you might need a replacement. So too much compression, ignoring the pain that comes with it, is a recipe for not helping the hip. But you can't say this is always going to happen.
Yeah. And I mean, a caveat to that is that, yes, I mean, the pain actually, to be honest, started when I tried to add a little bit of running. And I was a great runner in my teens,
Right.
Actually, I won everything. I was very, very, that was my best sport, long distance running. And when I come back to it, I thought, let's give it a little go. I was like 38 or something, 39. And I started and I was getting pain and I ignored it, and now, it's not gone back to normal. It's not right there. But what could it be? I mean, people are now mentioning hip pain to me as well, more and more. Are there different kind of things that could happen there in the joint?
Oh yeah, there's a host of
and
things.
What's right? Okay. Well, what's the solution in different cases? Can you flesh that out a little bit more?
Sure. Well, first of all, I'm not a physician. I'm not a therapist. I'm not a doctor. So the first thing I would ask anybody coming to me with these complaints is, what did your doctor say? And if they say, doctors, what do they know? Well, they know more than I do. So if they have gone to the doctor, I'd say, okay, what's the MRI show? What's the X-ray show? And all those things you have to take with many grains of salt. There's one a Montreal physician who got into this whole area of physiology. He once showed me an X-ray and says, okay, look at this X-ray. Can you tell me if the patient is alive or dead? You can't. The X-ray can't tell you some very basic things, like is this a dead person or a alive person?
Right.
So they can help guide your exploration, but they're not the definitive thing. As I said, a lot of people have torn meniscus, but they have no pain. So in the hip, it could be bone-on-bone compression that's wearing away the cartilage lining the end of the hip socket. There's a little lip there called the labrum. It could be that the ligaments that wrap the joint, these are called the capsular ligaments, it could be that they've been overstretched. trying to get your foot back behind your head is going to put a tremendous tensile stress onto those ligaments. So what you may be feeling there is just you've torn the capsular ligaments. It has nothing to do with the joint itself. It's the tissues lining the joint, around the joint, that's hurt. So there's lots of different things that could be going wrong. You could have arthritis in the joint. It could be an overuse system. Like a lot of runners, they've been wearing that joint out so that the cartilage at the end of the bones is worn away, and now it's bone-on-bone compression. That really hurts.
I bet it does,
There's so many things that could be. You actually need to have the MRI to go in there and see what's actually happening.
Yeah, I had an X-ray, didn't show anything. Nothing at all, no problem
the X-ray
there.
will only show the bones, it won't show the soft tissues.
Yeah, no, it's fine. Bones
the MRI
right.
will show this.
Yeah. The MRI.
But again, you have a lot of false negatives, or false positives, rather. Just for a second, let's just talk about the spine for a moment. In between the vertebra, there's a little jelly donut there called the disc.
Yeah.
Now, sometimes the jelly in that donut gets pushed out to the back, and you get a bulging disc. Well, it used to be anyone who had back pain, they'd go and get an X-ray or some imaging, and it would show a bulging disc, and they thought, well, the disc is pushing on the nerve root, we have to do an operation. But sometime around the 1960s or 70s, they realized, well, most people have a bulging disc, but they don't have pain. But if you have pain, you go get an X-ray, they'll probably find a bulging disc. Now, the statistics here are easy to remember. 30% of 20-year-olds have a bulging disc in their lower back, and they don't know it. There's no pain. 40% of 30-year-olds, 50% of 40-year-olds. See the pattern? 60% of 50-year-olds, 70% of 60-year-olds, 80% of 70-year-olds, and then 86% of 90-year-olds have a bulging disc, and they're completely asymptomatic. So imagine you're in your 50s. There's a 60% chance you already have a bulging disc, and now you're getting back pain. You go get the X-ray, and they say, oh, I see where your back pain is coming from. No, it's always been there. The same can be with the hip. A lot of people have torn labrums, and they don't even know it. So you can get an X-ray, and the guy say, okay, I see a torn labrum there, but I don't know if that's causing your pain because I don't know if it was there before. Do you have an earlier X-ray, like 2 years ago? So if you had an early X-ray 2 years ago, and now you see there's a torn, and it wasn't torn before, now you've got a bit stronger of a clue. Something happened there.
It's kind of surprising hearing a yoga anatomist talk in this way, because what you're saying is there's this factor that's just unknowable, really, that it's not mechanical, that there's what's causing them pain may not be identifiable exactly. If two people have the same tear, one feels pain, the other doesn't, then there's a kind of, there's a factor there, which is energy, really, isn't it? That's all you can really talk about in the end, that there's something there which is, you can't see.
Well, one of the people in this whole area that I admire quite a bit and respect his opinion, Professor Stuart McGill, he's a spine biomechanic. He spent his whole career studying the spine, creating all sorts of weird testing protocols and measuring how much stress it can take and what muscles are turning on when you use your back. What he suggests whenever somebody comes to him, and he's had people from all walks of life, elite athletes and NBA players, NHL hockey players, he says, look, you can always do the surgery. Let's leave that as a last resort. Instead, let's do a virtual surgery. What does that mean? Well, if you're going to get surgery, first of all, before you come into the operating theater, the doctor will prescribe you some things to do. Like, let's drop a few pounds, let's stop smoking, let's quit out, 4 packs of beer a day. Let's just get in general health together. And then let's come and do the surgery. And then afterwards, we'll give you some physical therapy to do. So McGill would say, okay, let's do all that without actually doing the surgery. So I'm going to give you the pre-op routine, and then we're going to pretend that on next Tuesday we had the surgery. I'm going to give you the post-op routine. Now, after your knee surgery, you couldn't walk like you used to. You walked probably okay. You probably didn't need crutches, but you weren't sitting on your heels the next day. You probably had to take some time off from your yoga practice, or you modified it just at upper body. Meanwhile, your lower body was resting. So let's do that rest anyway. Let's just pretend you can't move now for a couple of weeks and just do very gentle movements. Let's build it back over the months and the weeks. So let's do this whole thing as if you've had the operation but don't have the operation and see how you do. If that doesn't work, you can still have the operation. But generally, when he has people go through this whole routine, they're fine.
Well, that's a certain argument, isn't it? Maybe to have more patience than just sign up straight away for an operation, isn't it? But I suppose people will
But also, you still have to do what he said. You still have to
yeah,
back off,
yeah,
not
yeah,
keep putting your foot behind your head. Give it several months,
yes,
like you would if you had your hip replaced or
yeah,
something, and rebuild it over time, gently, working back to it. Now, most people don't have the patience to do that. When you have a
yes, that is
surgery,
one
you
thing.
don't get a
Yeah,
choice.
yeah, yeah,
You have to follow the protocol.
yeah, yeah. Yeah, there is an intangible there, isn't there? I mean, I remember the study. There was a famous study, wasn't there, of people X-ray for back pain. And it's like or MRI, and these people, they said, should definitely have back pain, and they didn't. And then vice versa, those people that
Right.
were complaining of great back pain, they couldn't really find anything there that was causing them the back pain. So I mean, is this just mind over matter, or is there something else that we can talk about here? I'm always reticent to say, well, it's just in the mind, because especially when people are
No.
in pain, it's like, well, to say that to them is like, it's really unfair as well. It's like, well, they actually feel pain, they do feel pain,
Yeah, I
But
mean, if somebody has a big cut with a knife and their hand hurts, you can see it's a physical cause.
yes,
So
exactly,
pain
yeah,
is physical, but pain is also neurological and pain is also psychological. It's not just one thing, it's a whole host of things. So the whole branch of modern pain science is quite big nowadays. It's not just physical, but it is physical. It's not just
right,
psychological, but it can be psychological.
mm,
There was a pivotal study done probably 20 years or more now in the Boeing factory down in Seattle. And they monitored 4,000 Boeing employees from all parts of the company. People in the factory putting planes, wings on, people driving trucks, people in their office, at their desk. And they tracked how many people got back pain. And the only thing they can correlate the back pain with wasn't the job they had, but how much they liked their job. People who hated their job had lots of back pain. People who loved their jobs had no back pain. So there's a
right,
psychosocial element to pain. So today we have something called the biopsychosocial model of health. Biology makes a difference. Psychology makes a difference. Your social environment makes a difference. All these things can contribute to or make pain worse or longer. So you can't just point to one thing anymore. You have to look at the whole garden. Why aren't your roses doing well? Well, maybe that oak tree's gotten so big it's shading the roses too much. Or maybe the water is being sucked away by the tree. Or maybe there's too many aphids and you need to plant some broccoli over here to draw the aphids away. You have to look at the whole person, not just what's happening in your hip.
Let me just kind of wrap up the interview by asking, what's the most surprising thing that you've learned over the years, that you've discovered in doing all this anatomy work, and getting involved in this, and how has it impacted your own practice and the way you approach your own body?
Well, the most surprising thing, I got to give credit to Paul Grilly, is just opening my eyes to the fact how different we all are.
Right.
My anatomy view was, here's an anatomy book. I memorized an anatomy book, and it shows every hip socket in the same place. And Paul said, well, that's not true. That's an average. It's a composite of hundreds of cadavers. Some people have hip sockets out. Some people have hip sockets in. And once I realized that, and I started to realize how that affected my own body and how my left hip was more retrograde than my right. So now if I'm doing half lotus, I'll always do it on my left side. That's my good side. And if I'm going to do eagle pose, I'll do it with my right leg because that's my internally rotating side. So that just changed my whole practice. I got to accept the things my body could do, and I got to completely forget how I was supposed to look.
But if you're not going,
my favorite saying is,
sorry.
Right?
Yep.
One of my favorite sayings is, we don't use the body to get into a pose. We use the pose to get into the body. We don't use the body to get into the pose means we don't try to torque the body to get a shape. Instead, the shapes are in service of creating some appropriate stress into the body. That's what we're after. So who cares what it looks like? What's important is, what are you feeling? What does it feel like?
How would you teach from that perspective then? Because I know you teach as well. And I mean, then if you're not teaching from symmetry or alignment or a certain particular anatomical protocol or vision, it makes things very, very complicated. If you can't say, well, this is the way this joint moves, or if you can't say this is the way that this pose should look, then how the hell would you say anything to anyone in the end?
Yeah, I usually get this reaction and question often. Paul
Right, right,
Gurley
right.
says when you first start to understand this functional approach to yoga, as opposed to an aesthetic approach is trying to make everyone look the same. That's aesthetics.
Mm,
Function is you want everyone to feel something in a targeted area. When you
mm.
first get presented with this, you kind of go through the 5 stages of grieving. First is denial. Yeah, he can't be right. That can't be what he said. And then comes anger. Now, I spent $3,000 in a yoga teacher training telling me how to get everyone to look the same way. And then comes bargaining. Well, what about if it's like this or this? And then comes depression. Now I don't know what to say anymore. I don't know how to teach. I'm just going to quit and go to join a convent or something. But hopefully at the end, you'll get this acceptance and you start to integrate all this into your own teaching style. I'm not anti-alignment. I'm just anti-universal alignment. There's no one alignment that's going to work for every body, but there is an alignment that's going to work for your body. So I like to think what I do when I teach is to give everyone flying lessons. They're all up there in their own plane. They have to take responsibility for landing the plane. But some of them are flying 747s, and some of them are little Cessna 150s. Everyone's plane is different. So I'm going to have to teach them flying lessons. And by that, I teach them what their plane can do. So when I teach down dog, for instance, I don't give them directions of where the feet should be, where the hands should be. First time we come down dog, I'll say, let's experiment. Have your hands as wide apart as the mat, palms facing out. How does that feel? How does it feel in the shoulders, the spine? Do you feel comfortable, safe, secure, solid? Now let's try it with the hands shoulder width apart, fingers pointing straight ahead. How does that feel? Now try it with the hands together, fingers overlapping. How does that feel? Now, of those 3 positions, which one felt the best in your body today? And if that's the way you felt best, I don't have to tell you anymore when we come to down dog, that's where your hands go. And the same with the feet, and the same with other body parts. I let them figure out what their plane can do.
Yeah, yeah. That's a lot of responsibility in the student then, isn't it? No, it definitely.
Well, I don't want to take the responsibility of telling them what to do because I don't know their bodies. I've never flown a 747.
As a segue, as a kind of a very, very brief sidebar, what do you think about carrying angles? Someone to me recently worked at a workshop. I was suggesting, myopically, that the hand should be straight forward if possible in downward dog or in jumping and etc. And say, well, Matthias Ratti, who was a teacher of mine, in fact, was talking a lot in her later years about carrying angles, and so I then researched online. It did seem to bear out that some people ought to have the external rotation of the shoulder in downward dog and this kind of thing, or jumping through. Do you have anything to say about that? Because I'd really personally be interested.
That's part of my last book, Your Upper Body Yoga. I talk about the carrying angle. If people in the audience don't know what the carrying angle is, if they just stand in front of a mirror with their hands at their side, palms facing the mirror, they might notice that their upper arm and the lower arm form an angle. Now, on my left arm, I don't have an angle. It's completely straight. But my right arm goes out to the side about 12 degrees. Now, the average person has about a 12-degree carrying angle. And it's because the alignment at the bottom of the humerus, the distal part of the humerus, it's on an angle. The condyles are on an angle. So that makes the forearm go off to the side. Now, when you pronate the hand over, that masks the carrying angle. So many people can get their palms almost shoulder width apart because they're pronating. But some people have a carrying angle of 25 degrees. And when they pronate, they still have a 15-degree carrying angle. Now, for them to bring their hands shoulder width apart, they have to internally rotate at the shoulders.
Right.
So, well, what do you want? I want the shoulders to be neutral. So the hands can be neutral. So start with the shoulders first, and then the hands will go where they go. And if that's wider than shoulder width apart, so be it.
That's a lot clearer, actually.
Plank
Thank you
pose.
for that. Yeah.
Same in handstand.
Thank you for that. That's really helpful. Okay, so finally, I don't want to take too much of your time up, but finally, how does it affect your own practice? Have you brought it, most changed the way it's changed your own approach? I suppose you've probably said it mainly, but there's probably something else you can say about it. Yeah.
Well, first of all, I now recognize when I've hit the limit of how far my body can open. I now know what compression feels like.
Right.
So once I reach the end of a range of motion, I don't try to go further. I'm not afraid of being at my end range of motion because you need to stress the joints. You need to stress the joint capsules and the bones, but I'm not trying to go past them. I'll never put my foot behind my head. I just don't have the hips for it. But now I know enough not to try. To try it, I'm just going to break the hip open.
Yeah.
So it's given me tremendous permission now not to have to do poses that I just can't do.
Yeah, that's fantastic. Yeah. let's see. Let's see if people give themselves permission on the back of this podcast. I hope so. You've given some great ideas and sharings, and yeah, I mean, I think there's this feeling that, well, someone else next to me can do it, so my body ought to do it as well. And if I don't achieve it, then I'm letting myself down or not trying hard enough,
Right.
or something wrong with me and my body. But it's actually, well, like, you didn't make your body, so you're responsible for what it can or can't do. So yeah. And people will always say, well, what does pain feel like? And I don't know. I mean, can you say, just to wrap it up, can you say anything on that? Because that's the last thing that people will say. Well, how do I know if I'm doing an injury to myself, or if it's just uncomfortable? Should I just be comfortable all the time? And you talk about stress and exercise being uncomfortable. It is, but on the other hand, it shouldn't be painful. And it seems that we struggle with recognizing the difference between the two sometimes.
Yeah, because we like black and white answers. We have trouble with grayscales and spectrums. The same with pain. Pain is a subjective experience that someone's having. There's no way to quantify that. You get some people, it's like Monty Python's Search for the Holy Grail, where King Arthur is jousting with the Black Knight, and he cuts off his arm, and he says, "That is a flesh wound." Cuts off the other arm and says, "What a scratch. I've had worse." Some people are like that. You see them holding chaturanga, and you go up and ask, "How are you feeling?" "Fine, fine. This is going to be so good. I'm going to be so sore tomorrow." They don't know what pain is at all. They have no idea. But there's other people who the slightest sensation, "Ooh, what was that? Ooh, I better back off. I'm not sure what that was." So it's not a black and white thing. Everyone has their own subjective experience of it. All I can tell you is, over time, if you start to build your interoception, your ability to know what's happening in your body, which is part of flying lessons, you have to teach the students how to pay attention. So when I've got a student in a pose, I'll tell them, no pain, no pain. Not like the West where we say no pain, no gain. If you translate no pain, no gain into Sanskrit, it's rendered bullshit-tihi. No pain, no gain, bullshit-tihi. Pain is anything that's sharp, burning, stabbing, electrical, tingly. That's just a rough description. But if you're feeling those things, your body's trying to tell you something. Back off. But for everybody, they've got their own. Some people, they have a whole scale before pain called discomfort. And once they're in the highest level of discomfort, then it becomes painful. Other people, their internal pain thing is right from just a little bit of discomfort to pain. And they only have like 2 or 3 steps. That hurts really quickly. Other people, as I say, the arm could be falling off and I don't feel much. It's okay. It'll be fine. So it's your airplane. You're going to have to figure out what pain means for you. And the other part of that, Adam, is when people are in chronic pain. When I'm dealing with somebody who's in chronic fatigue syndrome or chronic pain, and I tell them, don't be where it's painful, they just look at me and say, la vie est dure. Life is painful. Everything hurts. So in that case, okay, does this make it hurt worse? Not only while you're in the pose, but when you come out, and then the next day or two. So you can't just look for pain at once. It's while you're in the pose, if it hurts, come out. After you came out of the pose, did it hurt? In which case, next time, remember that. Or over the next day or two. That's usually where nerve pain shows up. You start to feel the tingling. You have to think back, what was I doing yesterday? Oh yeah, drop backs to wheels. Now I'm getting the tingling in the fingers. Maybe you're destroying the brachial plexus.
Right. Okay. Yeah. I mean, I think the thing is with what you're saying is that, yes, there's a lot of grey areas, but you're giving a good framework for the individual to liaise and kind of journey through those areas, and find out for themselves. So, it's like, yes, everything isn't black and white, but there's definitely frameworks like you suggest with the pain to rather than just like, I don't know anymore, like or I don't know how to teach if I don't do exact parallel alignment with heel to heel and, whatever, straight arms, there is a lot around this. And it's just amazing to hear this kind of thing. And I think it's so important in the yoga world. And again, just thanks for your time. And I'm hoping for a trilogy here as well as your book. We're going to tap Bernie again if he's up for it. Then we'll try a third one in another 6 months or something. And it's just been great, Bernie. Thank you very much for your time. And
Thank you, Adam. It's fun. Take care.
Thank